Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This presentation is being given in honor of Mental Health Awareness Month and is titled Understanding Depression, Insights, Strategies, and Support. The presenting providers are Trinity Health IHA Medical Group family medicine physicians, Dr. Cheema and Dr. Berry, who see patients at our practice in Livonia. So please take it away.
Thank you so much. I appreciate the warm handoff here. So again, my name is Dr. Cheema. I am one of the family physicians within IHA, and I've got my resident physician, Dr. Berry, who is a wonderful physician and will also be doing part of the presentation. We just wanted to introduce ourselves, and we're both family medicine physicians, and we both have interest in one, mental health, and also how we support our patients through any mental health struggle. Uh, so first of all, and let me just get this. Okay, so everyone has a story. So before we really start into the deeper discussion here, I wanted to share my personal story of mental health and depression. Um, I didn't recognize it initially. It was during residency time and after I had actually given birth to my first child. And about 6 months afterwards, I myself didn't notice it, but my husband did. How I was very irritable and wasn't really interested in the same things that I was as before, and also I couldn't sleep, and I was just having such hard time getting to sleep. Even if I did fall asleep, I couldn't stay asleep for more than a couple of hours with thoughts just running through my head all the time. And it was really affecting me. And I almost one day I just broke down and I said to my husband, I'm like, Sonny, I can't sleep. What do I do? How do I get through this? And I thought it was just normal life circumstances. I'm taking care of a baby. It was 6 months old, but also, working 80 hours a week. So this is all normal. However, it wasn't, because it was affecting me in so many different ways. And it was definitely had been around for, a month or two at least. So my husband actually recognized that and said, "Hey, do you think you're depressed?" I started thinking then with my physician mind and said, maybe I am. And I went to my physician and got help. Since then, it's not been completely smooth sailing. However, with medications and also with my family support and learning coping techniques, as well as putting in place different systems for myself, I feel like I have really not overcome, but managed my depression in a healthy way. So that's, I wanted to share, because depression is real and it can affect anyone at any time. And it is really hard to talk about. However, you have your family doctor, you have physicians, and also family members that are there to support you, and also friends. So we want to get the word out, how to recognize depression and how do we get people help. So just a overview of what we're going to discuss today. What is depression? How do we screen for it? And why you should talk to your primary care doctor about mental health, and also why it's important. And then Dr. Berry will go over some treatment options and also resources that can be very helpful for patients. So depression comes in different forms. So it's a real medical condition. Okay, it has emotional symptoms, physical symptoms, and it's not just a temporary feeling of sadness. It is usually persistent, so at least 2 weeks of feeling this way. You can have lack of energy, your sleep can be affected, your focus, how you move about your daily experiences, and also you may get delayed, you may not enjoy the same things as what you did before. So people can have varying symptoms, but they can be emotional versus physical. So physical symptoms could be things like you are eating more, or the opposite, eating less. And so you've lost weight. Um, it may also involve, again, either sleeping more or feeling tired, that lack of energy. And then with the emotional symptoms, lack of motivation. And it can affect people in many different ways. Some people feel that sadness or wanting to cry or feel like they're crying for no reason. But then there can be also irritability, anger, so these types of emotions can show up in, and may be prevalent for some, but not for others. So, what causes depression? Well, there's lots of different causes. There can be genetic causes, biological, environment, and psychological. So, genetics basically means that, if a patient has family history of depression, so their parents or grandparents, while you might be a little bit higher risk of depression. But the other part is actually our how our brain works. So our brain has these little um, uh, little receptors which connect our cells in the brain. And what happens is you have less of those chemicals being transferred between one cell to another. And so that's what you might have heard as a chemical imbalance in the brain. So for some patients, that may be a genetic variation, or it may be caused from environmental exposure, going through adverse events like a, a significant trauma, or stress, life stress in itself, and or different life events. Biological causes. So that is something that can mimic depression. So one of the most common ones can be thyroid issues. So if your thyroid's not working well, or it's not functioning well, and not creating enough hormones for your from your thyroid, then that can mimic depression. So we really, when you're talking with your physician, the physician really tries to take into account, okay, what could be the causes for the depression. And we want to make sure we rule out all of the most common biological causes, while also looking into, hey, what's happening in your personal life? What could we help with that might improve these symptoms? There's lots of different risk factors for depression. Women are at a higher risk. If you have a history of anxiety, or low self-esteem, or previous episodes of depression. I also mentioned with the family history, that is quite significant too. We can also see higher rates of depression when someone has had a stroke recently, or they've had a heart attack, or a new medical diagnosis. So sometimes it can take a while for that to show up, but it is something that we should be looking out for either our loved ones, or anyone that we know that might have gotten a significant medical diagnosis. And also having a chronic condition. Many times, patients with chronic pain, that is, affects their mood, their quality of life. And so that is something that we should be looking at as well. And again, I mentioned the family stress, the different kinds of life events that you may experience. The prolonged high levels of stress can increase your risk for depression. So, how do we actually screen for it? So, when you go to your doctor's office, the annual exam is usually the first, point where we usually screen for it. But now we screen for it at every visit, at least within our IHA and Trinity Health family, because we want to catch this early and help you get your resources and treatment early. But what we use is a questionnaire. And so you may have seen what's called the PHQ-2 or PHQ-9. We usually start off with the two simple questions of asking, okay, in the last 2 weeks, how often have you been bothered by little interest or pleasure in doing things, or feeling down, depressed, or hopeless? So if a patient answers one or more, usually they will then go to the PHQ-9 screening, which lists a lot more of those symptoms, the emotional and physical that I talked about before. But generally, this is the way that we screen for it. We also use this to kind of see how you've been doing if you were diagnosed with depression, and how do we kind of gauge where you're at, whether it's mild or moderate or severe, and we also make sure we screen for thoughts of whether you would be better off dead or hurting yourself in some way. Those are some important questions that we make sure to ask. Now, obviously, some of these questions are sensitive, and so if especially the last question, if it is marked down, it's part of our responsibility as physicians to ask you more about it, and figure out, hey, how can we get you help? So this is one form of screening for depression. There are other templates, other instruments, but this is the most common one that we use uh, in Trinity Health and other locations and health organizations. So, what about, how often should you have it done? You should have it at least done every year. With your physical. But as we do in Trinity Health, we try to screen you as often as possible to catch, people at different times of the year. So, all right. So, why should you talk to your primary care physician? Well, they know your medical history. They can screen for this and also rule out other medical conditions. They can really help you too, and I do this, and Dr. Berry does this as well with our patients, of really figuring out what's going to work best for you. Whether that is making small goals with your physician, or is it counseling, or is it medications and counseling? So we really try to cater that treatment plan to you specifically. Luckily for us, we have behavioral health within our support staff. So the great thing about our offices is we have behavioral health embedded. So meaning there is a behavioral health specialist that helps with, one, getting you the resources for counseling, but also doing a little bit of cognitive behavioral therapy, which Dr. Berry will talk about further. But that is a resource that we offer to our patients free of charge, and it has really helped kind of further the conversation of how do we get you help earlier on. And just again, mentioning, it's really hard, I think, for a lot of people to talk about their mood and mental health and what's happening. And we recognize that this is something, that obviously is very personal. And when someone brings this to our attention, or a patient or a family member, we really want to commend you for bringing it up. It's why we screen, and it's why we really put a big effort into mental health resources, because we know that diagnosing early gets you earlier treatment and reduces risk of further worsening and also decreases your risk of further episodes of depression. Right? Okay, so I'm going to hand it off to Dr. Berry, and she's going to go ahead and talk about treatment options.
Hello, everyone. I'm Dr. Berry. I'm a second-year family medicine resident here at Trinity Health, Livonia. What I love most about being a PCP or a primary care physician is that we serve as the frontline responders in identifying, diagnosing, and treating mental health conditions in our community. Today, I would like to use my time to share with you some important treatment information and resources for MDD, in other words, major depressive disorder. So for treating MDD, as you can see on this slide, we have two major treatment options. We have medications and therapy. There are many medications on the market, and their main goal is to correct that hormonal imbalance in the brain that Dr. Cheema was referring to earlier. These medications come as different classes. Some of the common ones are SSRIs, SNRIs, TCAs, atypical antidepressants. You may or may not have heard of some categories. Some of the common medication names are Zoloft, Celexa, Lexapro, Prozac, which we use more commonly. Something to know about these medications is that they typically show results in about 2 to 4 weeks, and they can take up to 6 to 12 weeks to show peak effectiveness. Let's talk about behavioral therapy briefly. It includes options like CBT, talk therapy, self-directed therapy, group therapy, and to be honest, there's a lot of different types of therapy options out there. CBT is one of the more common and more preferred, or I would say preferred option these days, because it really focuses on changing those unhelpful or unhealthy thoughts and behaviors that might be kind of linked to the cycle of these depressive symptoms. And research has suggested time and time again that a combination of medications and therapy gives the best outcomes in helping manage depression symptoms. So we'll move on to the next slide, and we'll answer some common questions regarding treatment options. So the first question is, are these medications addictive? I ask a lot. And the answer is no. These medications, they don't cause cravings, and there's no tolerance to these medications, unlike other addictive substances such as alcohol or opioids, etc., that's out there. However, it's important to know that abruptly stopping these medications can cause discontinuation syndrome, which may present as flu-like symptoms, irritability, or sleep disturbances. Therefore, it is really important that you taper off these medications safely under your primary care doctor or your doctor's supervision when you do plan on stopping these medications. All right, next question is, how long would I need to take these medications for? And the answer to that is that it totally depends. If this is a first-time episode, treatment for at least 6 to 12 months is recommended to prevent further episodes. But if you are someone who's having recurrent episodes, then one can continue on these medications for much longer and many years. All right, question 3 is, how would I know which antidepressant will work for me? And I get this question asked a lot. So there's many options in the market to choose from. Typically, I will begin by asking if anything has worked for you in the past. Maybe you were on Zoloft 20 years ago and you responded really well to it. And then that might be a medication that we might choose to start you on. Sometimes, if you have not been on any medications, but someone in your immediate family has been on a medication that worked really well for them, for example, if my patient tells me that her sister takes Lexapro and has done really well with Lexapro, that might be my first choice for them. And this goes back to the genetic connection that Dr. Cheema had mentioned earlier. Additionally, sometimes I will pick the best medication based on what desired results are we looking for in addition to treating the depressive symptoms. For example, if someone has been sleeping too much, maybe starting them on a medication that's a little activating and gives them a little more energy might be a good idea. Or if someone's sleeping too little, then maybe giving them a medication that helps them sleep might be a good idea. So there's different ways we pick the right medication for you. Question 4 is, what are some common side effects of these medications? So common side effects include not GI upset symptoms such as nausea, diarrhea. Headaches are a common symptom as well. Sleep changes, sexual dysfunction with some of these medications, and increased anxiety early on in the course. Therefore, it is really important that we know what these side effects are so we can identify them early. It's also important to start on a lower dose of the medication and gradually build up the dose to help mitigate some of these side effects. Another thing you can do is take the medication with food if GI side effects is what your main issue is, and that can help with mitigating that side effect. And you can consider a morning dose versus an evening dose based on if it makes you too sleepy, maybe take it at night. If it activates you a little more, take it in the morning. So different ways we can kind of work around these side effects. The next question is, can these medications interact with my other medications? And the answer to that is yes, absolutely. Please do not take these medications with alcohol or any kind of opiate pain meds. And it's very important to discuss potential medication interactions with your primary care doctor or psychiatrist before you start these medications. And the second last question is, what should I monitor for at home once I start taking these medications? I would recommend, monitoring your mood, signs of irritability, your sleep, your energy levels, your appetite, to name a few things. And the last question is, can I take supplements instead of SSRIs to treat my depression? You should definitely take vitamin D and vitamin B12 supplements if you are deficient in those, as they could be contributing to your symptoms. There are supplements out there. There's omega-3, there's St. John's wort, there's magnesium, ashwagandha, there's L-theanine. They all may provide some benefit. However, the evidence for most of them is not strong or consistent when it comes to treating to severe depression. And importantly, they're not a replacement for proven treatments like antidepressants or therapy when those are indicated. For mild depression, sometimes just lifestyle and nutritional changes might be enough. All right. A slide showing how treatments can be escalated based on the severity of symptoms. It's important to pay attention to the row I have on the screen. Treating depression is a team effort, and you are the most important person on that team. Our role is to offer you the tools that are proven to help, but your input and your choices will guide how we move forward in our management. There is not a one-size-fits-all treatment, and what works for one person may not work for another person. So we really value hearing from you, how you're feeling, what's working, what's not working, and what matters most to you. It's important to remember that recovery isn't always a straight line, and it's normal to make changes and adjustments to the treatment plan as we go along when we're treating depression. And I have some resources that are listed here on the next slide. So obviously your primary care physician, psychiatrist, or counseling practice can be a major resource for you. There are support groups, both in person and online, that can be very helpful. For example, there's a Depression and Bipolar Support Alliance. That's a very famous one. And then there are online therapy plans for self-directed therapy. I've listed some online therapy apps, and that might be helpful to some of you. I would recommend exploring them along with some mobile apps for self-tracking and support. You could also plan through your insurance or employer to see what kind of resources are covered through your insurance, what therapists are in network, and what kind of counseling and therapy might be covered through your insurance plan. There are community mental health programs as well that are individual to different communities. One website that I really recommend is psychologytoday.com. It has an option for a therapist finder in your neighborhood. So you put your zip code in and it lists all the different therapists in your neighborhood. And it also lists what insurances they accept. Another thing on Psychology Today is they offer CBT-based or cognitive behavioral therapy-based education sheets that are used as a self-directed learning therapy option. And it's important to know that we do have a suicide and crisis lifeline. That's 988. And we also have a crisis text line where you can text home to 741 and 741 for any immediate assistance. And we'll go to the next slide. I would like to wrap up by talking about sleep. Sleep is one of the most powerful tools that we have for our mental health. When we don't sleep well, it affects the way we think, feel, and cope. And this can make depression much harder to manage. In fact, poor sleep can be both a cause and a symptom of depression. But the good news is that improving your sleeping habits, what we call sleep hygiene, can really help improve your mood and energy. Sleep hygiene means building habits that make it easier to fall asleep and stay asleep. Think of it like training your body to expect rest. Take a minute to read some of these tips that are shared on the screen. You don't have to make all of these changes at once. You can start by taking small steps and making one change at a time that is sustainable and achievable for you. And lastly, please remember that you do not have to do this alone. We are here to support you every step of the way, but the progress that we make will be built on your efforts and your voice. I hope that this information was useful and will allow you to feel more prepared and informed when discussing mental health challenges with your doctor in the future. Thank you.
Thank you, Dr. Berry. We are going to go to the questions.
Yeah. So Dr. Cheema and Dr. Berry, I'm happy to help read some of the questions for you, but please feel free to also read along. If you see something that I'm not seeing, you can absolutely call it out.
Okay.
So I am going to kick it off. How do I find a counselor who knows about caregiving and anxiety as well as depression?
So most counselors will or therapists will be able to help with the variety of those symptoms. But sometimes it can take a little while for you to find someone that really either gels with your personality or the communication style. So I think one way to go through that is one, asking your physician about what their recommendations would be. The other way is, there are online therapy groups like BetterHelp. I know they ask you different questions to kind of figure out what preferences you have and also what would align as far as therapy. But I would say majority of the therapists should be able to help with the caregiving stress and what kind of coping techniques can be built through that, and also help with the anxiety and depression portion. Do you have anything to add, Dr. Berry?
No, I think you answered that one pretty well.
Oh,
Okay. This person says they have anxiety and depression. However, they're allergic to most psychotropic medications. What is the best therapy option for them?
I
so
can answer.
go
Oh,
ahead.
sorry.
Yep, go ahead.
Well, in terms of therapy options, if you've tried a few medications and they've not worked well for you, considering cognitive behavioral therapy or counseling might be an option and might be way through. There is evidence that they also work really well done independently. So that might be a route to consider if you haven't considered that yet. And there's also genetic testing available, sorry, go ahead, Dr. Cheema.
Yep, that's what I was going to mention is the
There's
genetic
also
testing. Yeah.
Sorry, I think there's a lag. So I'll just finish what I was. Is genetic testing available these days? We don't do it at primary care office, but I know a lot of our psychiatry offices at IHA offer genetic testing, and that can really help identify what medication will be best suited for you.
Okay, is that typically done through a blood test or how would you?
Correct.
Okay, perfect. So you can get a blood test and then that will give you an idea of the type of medication more specifically that will work for you.
Right. Now, some of these tests
Absolutely.
are out of pocket cost. Now, they used to be really expensive. However, they have gone down in price. I have researched myself. There's labs within Michigan, but also in Ohio that do these types of tests. And they may not be able to test every medication, but at least get some classes of medication that could be helpful. The other part is, sometimes medication treatment is not the route. It may be what is called ECT treatment, which is uh, is more directed by psychiatrists and is monitored therapy. It's electroconvulsive therapy. That's where, the brain gets reset by electrical current. But that's definitely more on the later types of treatments and is usually prescribed by psychiatrists.
Okay. This person is asking, is it normal to isolate when depressed, get shaky, have a body temperature change, flashbacks, feeling of disoriented or not knowing where you are? It looks like isolating in a fetal position for self-soothing. Comfort items such as pillows or stuffed animals to hug and release emotions are these exercises that will work for depression. So I guess let's start at the beginning of that. Is it normal to feel isolated and have some of those physical symptoms like shaking, body temperature changes?
So isolation can happen where you want to be just by yourself or, go into bed and hide under, the covers, etc. Um, some of the other symptoms that were mentioned, shaking or, temperature change, maybe not so much. However, if someone is going through a more of a like a flashback scenario, or could it be, something that's related to maybe PTSD or even a panic attack, those are manifestations, are different manifestations than depression. With the multiple symptoms mentioned, there might be a mixture of depression, anxiety, or having, post-traumatic stress disorder. Especially with the other symptoms mentioned, like the flashbacks or having confusion. Generally, confusion is not at the top, but people can feel foggy or, have lack of focus. That would be more consistent with depression.
Okay, and do you ever find that the symptoms are related to hormonal changes in the body as well?
So yes, I mean in perimenopausal women, as well as when women have gone through menopause, mood changes can happen, and so the fluctuating hormones. We do know that a lot of our patients who are going through that change experience or may experience heightened anxiety, heightened depressive type of symptoms, and so that's that one of those biological causes that we also look for when a patient is presenting with these varied symptoms.
Okay, and you talked about thyroid being a symptom as
Mhm.
well as one condition as well. Are there other
Mhm.
conditions that may mimic the signs of depression?
Mhm.
Yeah, absolutely. There are some of the more common conditions are vitamin deficiencies, which are pretty prevalent, especially in Michigan, with vitamin D being really low. Low vitamin D or vitamin D deficiencies can cause lower mood and depressive symptoms. Low vitamin B12 can also cause depressive symptoms. Sometimes depressive symptoms or depression be present in more can be present as like a part of other chronic conditions. For example, if someone is struggling with a chronic condition, um, chances of depression being prevalent are high. Um, there are certain autoimmune conditions where I've seen a lot of patients present with depressive symptoms as well.
Okay. And you talked about the screenings that patients can expect to receive when they come to an IHA practice. Are those done for teenagers as well? So if someone is coming with their 16-year-old child, do they need to specifically ask for that questionnaire, or is that something that's done in primary care and pediatrics?
So that is one of the screenings that we do. It may look slightly different for teenagers. However, starting at the age of 11, we usually do the PHQ-2 or the PHQ-9, but we also have this what's called a pediatric symptom or youth scale, and that also screens for mood concerns, anxiety, and depression. So you may see it a little bit differently for pediatrics or younger than 18, depending on which office you go to. But generally, it's in similar format, whether that be the PHQ-9 or the pediatric symptom youth scale.
Okay. Is there a relationship between a traumatic brain injury and depression?
Yes.
Do you want to answer that? Yeah.
Yes, there is. It's hard to, quantify. It can be present in patients with TBIs, concussions, for example.
Okay. Are there medications available for depression that do not have suicidal thoughts as a side effect?
So that's kind of a hard question to answer. I think the reason behind why suicidal thoughts might occur is that now you've got these chemicals being exchanged better within the cells in the brain. However, that also may bring about, certain thoughts. So the fogginess may disappear, or the lack of motivation may disappear, but you've still got that depression happening, and it's not completely back to normal. So these thoughts that might have been, on the lower side now increase, and so patients may have more motivation to do something about that harmful thought. That's one way that we look at it, but clearly there are uh, many antidepressants that could increase your thoughts of hurting yourself or thoughts of suicide. And I think education is a big part of this, but also having a safety plan. So when we see that a patient has more severe depressive symptoms, having a safety plan in place is really important. So, what does that mean? That means that having family support, okay, whether that be friends or immediate family. It also means having a written plan maybe down together with your physician, having more check-ins. So could be over phone or in the office, and then also making sure that we mitigate risks for suicide. So that could be asking, hey, are there any guns at home, or do you have access to weapons? Okay, and mitigating those risk factors can help reduce the risk of suicide. Or do you have anything else you want to add, Dr. Berry, to that?
No, I think, and just to clarify, those suicidal thoughts as a side effect are only a side effect in the initial phase of treatment with SSRIs. They're not a long-term side effect. Like Dr. Cheema said, it's just the first, I would say, 4 to 6 weeks where the chances of committing suicide can go up because you're still depressed, but the fogginess goes away. But after those 6 weeks, once the medication fully kicks in, then you should not be having this as a side effect of the medication. Just wanted to clarify that.
Okay,
And I think it
go ahead.
sorry, and I want to make sure that, if you are having recurrent thoughts, then reaching out to your doctor, or going to the ER may be a place to start, because it's really important to take that seriously.
Okay. Um,
I'm going to try to answer some.
Fred, I know there was a question from a caregiver I can call out. I saw one coming from a parent and one coming from a child. So a parent who is taking care of their child, adult child, who attempted suicide and now lives with the parents. And then also a woman who is the daughter of a patient who is being treated for depression. So if you are a caregiver and you have not been diagnosed, but you are maybe the main caregiver for someone who has, is that something that you could seek some treatment for?
I would say absolutely yes. It's, we know that if you have someone in your family close to you or a friend close to you who has attempted suicide or committed suicide, your own personal risk of being depressed and committing suicide or attempting suicide goes up. So if you know someone close to you who has been in that position, I think it is absolutely fair to talk to your primary care doctor and consider and start the discussion about maybe considering medications or getting therapy to protect yourself and make sure that you are taking care of your own mental health while taking care of your loved one.
And if you haven't been diagnosed with depression as a caregiver, could you seek out care kind of preemptively before maybe a depressive episode strikes, knowing that you're under the stress of caring for someone?
Right, absolutely. You should.
Okay.
And we in our offices we have social workers along with our behavioral health specialists, and we utilize our social workers to really help get resources for caregivers, and that might be sometimes additional resources at home, giving kind of respite for caregivers, so that they can also focus on their physical and mental well-being.
Excellent. That's great to know. There's another question here. What is the best way to help someone you care about to recognize there is an issue, especially if they're reluctant to even discuss this with their physician?
So I would say that I think one of the ways that I've taken care of a lot of couples and families, and so sometimes uh, a spouse or a partner will bring that up and say, hey, I'm concerned about my husband that you're taking care of, or my partner that you're taking care of. Could you check in with them? So that's one way. Now that may not always be possible, as I may not be their physician or their family physician. But other ways is, uh, gently kind of probing about, hey, how's your quality of life? You know, are there things that, you have stopped enjoying? So really focusing on that quality of life piece, and saying, I see that you're you might be stressed out, or hey, I see that you're not sleeping well. um, Maybe you want to talk to your doctor about your sleep. So sometimes utilizing those kind of objective things that you've observed, okay, to bring about, uh, let's have you talk with your doctor. I can help kind of make that appointment for you if you want. So sometimes using those kind of indicators to get our loved ones to seek out help.
And what are some things that a patient could say to you as their family physician to get that conversation started when it's hard to find some of those words?
So let's see. I think it's different for each patient, but you could say, you know, I'm really stressed, and I think it's affecting, my uh, my life overall. Those are some cue words to kind of point out. The other thing is, you know. Uh, Sometimes if you're not able to verbalize it, write it down. Okay. And the other ways that I've seen patients, bring it up is, you know, um, hey, do you think, I don't think I'm depressed, but these are the symptoms I'm having. Okay. I think it's important to uh, uh, express what symptoms you're having, and that can obviously, help your physician figure out, okay, is this something else versus, depression? Um, Dr. Berry, do you have some recommendations on how patients could approach their physician?
I just feel like if you just bring it up in whatever form you can, it's important to talk about it. And if you never bring it up we'll never know. We try to screen, we try to do our best, but we like to hear from you. And we just, most physicians, out there are, well, most of them will feel comfortable and would be willing to work with you and help you through this. So, just whenever you can, you should try to talk about it. It's hard. It's hard to talk about it, but always try to push yourself and try to talk about it. I know this answer isn't like what you were looking for, but I just wanted to kind of reiterate.
Yeah, I think it's important to know that your primary physician is there to support you and does care about your mental well-being as well as your physical. I think you've talked about the screenings that happen and writing it down. That's maybe a great opportunity to make sure you're answering those questions honestly. So your provider is getting a really good look at how you're doing mentally, perhaps. So it gives you a chance to have it in that written form without bringing it up verbally. There are a couple.
Yeah,
Oh, go ahead. Yep, go ahead.
yeah, I think one of the things is, I look at those screens, and I think that's the reason why we do it. But also, myself as a family physician, I get to know my patients. And so a lot of times what happens is, I will figure out just asking about their life, hey, something big has happened, and so different cues that I have for myself. But for patients, that can be sometimes hard to, because you're living it, right? And so you may not necessarily recognize it. So the idea is, when your doctor is asking about, hey, do you have any other symptoms? Uh, be as honest as you can, and and that will help your physician to really guide you in the right diagnosis and treatment.
Okay, excellent. Um, I'm looking here. In addition, with a primary care doctor and or a psychiatrist, if needed, would talking with a therapist be helpful? And how do you find a therapist that you'd be comfortable with? You touched on this a little bit. Is this sort of a trial and error thing, or can your primary care physician help you find someone that maybe lists a focus on a certain type of therapy?
Yes, absolutely. So we have resources for therapists in our clinic that we can share. We have, like Dr. Cheema mentioned, our own behavioral health specialists on site who can also help with providing a lot of these resources and a list of therapists in the area that will accept your insurance. There's also, like I mentioned, psychologytoday.com. You can put your zip code and find different therapists in the area. What I really like about that is you get to read about what kind of work they do and what kind of area of therapy they specialize in. And you can also read about just who they are and their background and see if that might be something that speaks to you. A lot of the time, that's how I've personally looked for therapists. And for example, if I'm looking for a female therapist who's a younger female therapist in this age group, who works with this kind of therapy, whatever criteria that I had for myself, I'm able to find that through that website. And it also tells you what insurances they accept. A lot of the times, you may not find the best fit for you the first time around. A lot of the times, folks do have to try, I would say, a couple therapists to find the person who fits best, speaks most to you, and is the best fit for you. But it sometimes it works on the first go, sometimes it doesn't. So it is a little bit of a trial and error.
Okay, and your primary care physician is a great place to start because they can kind of guide you in a direction of, I think that maybe you're experiencing more depression versus anxiety, or kind of set you on the right path. Perfect.
Absolutely. And there's also like different severity of depression. Like I had mentioned, this mild, moderate, and severe. Sometimes for mild depression, like I'd mentioned, just therapy can be the best answer, and we might not need medications at all in like milder stages.
Okay, excellent. Um, okay, this person says that they thought their mother was developing dementia and they went through all kinds of neurological testings and the results did not confirm this. So her physician suggested she may be experiencing depression. Can depression symptoms be similar to early onset dementia?
So I can answer that. I'm sorry, I was just typing. Uh, but so what's interesting is that there are studies out there that show that early onset dementia can mimic depression symptoms, and also that depression can mimic those type of memory loss or um, fogginess or confusion type of symptoms. And it can be hard to differentiate between the two. So I'm glad that that testing, all came back normal. However, I think you should still keep that, in mind just in case, and have because generally, I would say if you get treatment for depression, those memory issues or those memory concerns should improve. However, if they're not improving, then we need to be even more cautious about not ruling out dementia as a cause of the symptoms.
Okay. And this person says, I have heard that CBT is effective but not long lasting. What are your thoughts on the efficacy of CBT?
I would argue that CBT, in fact, is long lasting. And some of those skills and coping mechanisms that you learn through CBT, you can carry them with you lifelong, and they can really help you cope with different kind of situations as you go through life. And it can be a great tool for every person to, learn and use to help fight some of these depressions and anxiety symptoms.
Yeah. I think one of the things that I've learned, going through therapy myself is, that it is a work in progress. So, one of the things that my own therapist said to me is you need to set boundaries, right? So setting boundaries can be very difficult in different scenarios. However, that is something that I've worked on, but my therapist gave me, different ways that I could set boundaries, say for my work life balance, for my within my family, etc. But it didn't. It's not going to last unless I keep those boundaries in place and have a way for me to deal with, the stresses. So having your toolbox of, what keeps your mental well-being going. So that could be, oh, I take a 15-minute walk outside every day. Not in the winter time, or, I read a book. Or, I do self-care things like I enjoy cooking or baking, different kinds of things that you do for yourself to keep your mental health going. There is also, and I love this resource. It's called The Greater Good, and they talk about the science of happiness. And there are multiple of these podcasts that really focus on how to promote your own well-being, but also lead a happier life. And they talk about real issues and real things, and how do you, utilize music, or how do you utilize dance, different ways. Now, some things may not apply to you, but I think hearing other ways of helping reduce stress and reducing different symptoms that occur with depression, and finding what works for you, right? It might take a little bit of time, but sustaining relief, and sustaining that well-being, I know for myself will always be a work in progress, but for a lot of our patients, that happens too.
Okay, and someone is asking if you could define cognitive behavioral therapy. Can you kind of talk just a little bit about what that might entail?
Sure. I can talk about that. So it really breaks down into cognition and behavior. So cognition refers to like our thoughts, and some of them can be unhealthy thoughts when it comes to like, something like depression or anxiety, or thoughts that are, unhelpful for us. And then behaviors is how we respond to those thoughts. And a lot of the times we're kind of stuck in this loop of having unhealthy thoughts that are leading to unhealthy behaviors, and we catch ourselves in those in a loop when we're depressed. So cognitive behavioral therapy helps to break that loop, and it helps to kind of fix those cognitions and turn them into healthier cognition, healthier thoughts that can result into a healthier behavior, to like oversimplify what cognitive behavioral therapy is. And for like a more formal definition, I have it down here somewhere. It says it's a form of psychotherapy that focuses on modifying dysfunctional emotions, behaviors, and thoughts by identifying and challenging negative or unhelpful thinking patterns and developing coping mechanisms.
Okay, so frequently reading a question. So frequently we may hear on a TV commercial that they have a new medication that you have to take with another type of medication, and then the two work together. Can you talk a little bit about why you may prescribe two different medications for someone who's experiencing depression?
I'm sorry, can you say
Um,
that question again? I
Sure,
apologize.
sure. No, that's okay. So if a physician prescribes two medications to someone who's experiencing depression, what is a reason that that might be done?
Okay. So generally, we start off with one medication. However, if for some reason we're not seeing the effectiveness of it as much as we want, like it helped a little bit to kind of get your sleep better or to get your mood better. However, you're still experiencing the either lack of motivation or other symptoms, then we add what's called adjuvant therapy, which could be medications like Wellbutrin or Abilify or some of these other more newer medications. And they help that first medication work better, but also address those additional depressive symptoms in more of a mood stabilizing manner. So they work with the other medication, but in a different way.
Okay. And is there ever a concern that you won't be able to work or operate machinery, drive when you're on medications for depression?
So sometimes that is a concern. Now, with most of these medications, you should not have an issue, going to work and those things. However, if the depression is severe enough, then we have worked with patients, to either have time off of work or to, get that aggressive type of therapy done along with titrating their medications, meaning either increasing their medication or adding more medication and have them off of work while things stabilize out. Especially if they're functioning, so meaning they're having a hard time going to work or they're not able to, tolerate going outside because of extreme anxiety, etc. It's important for physicians to look at that, and like I said, we've given patients time off to get settled, and also it is in some workplaces that is a benefit. So it just depends on how severe something a symptom is, and also where you're getting treated, and how often you need to see the doctor. See, I am going to put here another question regarding Lexapro. Is it one that is more stimulating or sleep inducing? So, generally, Lexapro may be a little bit sleep inducing, but I can tell you that I have had patients that have said the opposite, but more often it is the sleep inducing part that is beneficial there. Um, but it can be activating for some, which is generally, it's kind of like a trial that has to be done. Um, I am not so sure about ketamine and mushrooms for treatment of depression. I have not really studied much about that. I do know that ketamine has been used for certain patients, but I would be not the right person to answer that question.
I can answer that very briefly. Ketamine is being used these days for treatment-resistant depression. What that means is if someone fails all the first line and second line medications that we generally use, such as the SSRIs or SNRIs, and you've also seen a psychiatrist and failed other more advanced therapies such as ECT, that then ketamine is something that is considered. Mushrooms, it's a very new field, and it's currently being researched. It is showing to have some benefits. The active components are showing to have some benefits with curing depression, but it is not something that has yet been incorporated into medical treatment as of yet.
Okay. Sorry, I was on mute. I was reading you a question and I didn't get off mute. I apologize.
That's okay.
Okay. Is it normal to still feel occasionally depressed while on medications, or is that a signal that a possible change in medication is needed?
So you can sometimes feel still depressed, and that's where, we will consider adding a different agent or switching the medication completely. And that's where I think a lot of patients may get frustrated because, they've had to switch, two or three medications because it hasn't helped. And I think that's one of the reasons why we will ask about family history, but also consider the blood test to help us figure out at that point, if certain medications have not worked or are as effective. I see one of the questions, when would we refer a patient to a psychiatrist? In this type of scenario where we've tried multiple medications, and they have not been effective, I think that is a point where we should be getting a psychiatrist involved. But also, if we have a concern for maybe some other mood disorders like bipolar disorder, or sometimes even with, I like to get help of my psychiatrist colleagues when we're thinking about a patient who has PTSD. or might have, again, that bipolar type of symptom happening. So those are important things to consider when we are talking about referral to a psychiatrist. Let's see.
Yeah.
So I see, can you do therapy and no medication? You absolutely can, and we do that, many times. I think uh, for a lot of patients that may be the route to go because it is mild depressive symptoms, and we can really work fast to help uh, correct some of those negative feelings and thoughts. Um,
I think there's some concern around weight gain with antidepressants. Is that something you hear from patients? And is there something you can do to help alleviate that if they're experiencing that?
Yes, I can answer this one. There are certain medications that that might cause some weight gain, but not all of them. So if that is a concern, we always try to pick the right antidepressant, and we try to pick the ones that are more weight neutral. And if in certain cases we are, for example, patient has been eating more as part of their depressive symptoms and their appetite has increased, we can also consider certain medications such as Wellbutrin that help with suppressing appetite a little bit, and that can help kind of counteract some of their symptoms. So it comes down to picking the right medication based on your symptoms.
Okay. I'm just cruising through here to see if there are any other questions that we may have missed. Do you see any that you'd like to read?
let's see.
I know someone's asking for you to restate the name of the website that you like, the definition of happiness. Was it the Goodness Project?
So it's called The Greater Good. And it is the podcast that is The Science of Happiness. And it's a free podcast. And also The Greater Good they release a calendar every month. And they have different activities that you can do on a daily basis. That may be reading an article or, doing something else to consider improving your happiness. And it's through Berkeley, just so you know, but it is a nonprofit group called The Greater Good, along with the Science of Happiness podcast.
Okay. Thank you for redefining that.
Yep.
I know a lot of people on here are talking about physical fatigue, being really tired, but not being able to sleep. Is that where you would play with medications when you're taking them, having a combination of medications? Is that kind of what you're talking about?
Yes, so we sometimes use sleep aids or sleep medication, which are helpful to get that sleep cycle back to normal. So I myself have recommended things like trazodone in addition to other antidepressants to help with sleep. We will suggest sometimes melatonin, and then there are other more prescription sleep aids. We try to not utilize those as much. However, based on what's causing you to not sleep, Could it be anxiety? You're having all of these thoughts. So sometimes we will use a medication called Atarax, which helps to kind of calm things down with anxiety, and help sleep.
I also thought your sleep hygiene slide was very important. So, doing some of the things outside of medication to ensure that you're setting yourself up for a good sleep.
Yes,
Absolutely.
that's
And
very
there's
important.
also there's
Oh, go
also
ahead, go ahead.
CBT that's focused on insomnia. It's called CBTI or CBT for insomnia, and that can be very helpful to folks who might have trouble sleeping.
Okay, perfect. Okay. Um, so it looks like somebody is asking, what is the likelihood of a child being diagnosed with bipolar disorder if the father is diagnosed? And how old should the child be to start looking for those symptoms?
I don't have an exact number for percentage chance, but I do know that bipolar disorder, more than depression, is more strongly linked to genetics. Um, if there is a strong prevalence of bipolar in the family, there is a chance, a pretty decent chance that um, it gets carried on into the next generation. Um, Typically, signs and symptoms, well, again, this is hard to say. Sometimes signs and symptoms of bipolar can present as early as like infancy and young kids, childhood. Sometimes they can present in their teenage years. Um, it always depends. It's hard to put an exact number and time on that from my end. If Dr. Chima knows anything else, I'm sure she can share as well.
Yeah, I mean, I think with diagnosing bipolar disorder, it can be hard to do that, but we do know that again, like you mentioned, there is increased chances if there has been a family member diagnosed with bipolar disorder. Um, However, things have changed over time. Even the criteria for diagnosis for bipolar disorder has changed over time. And also we know more now than what we knew 20, 30 years ago, and how bipolar disorder is treated has changed in many ways too. So if there are concerns for that, I think we have mood questionnaires that we do. Now if the child is very young, it can be hard for them to really answer those questions. But if we are really concerned, there are pediatric psychiatrists available within our organization, as well as local health systems that can be very helpful in kind of differentiating between major depression and bipolar depression.
Okay, so it looks like we've covered, I think, most of the major topics that have been asked in the questions. There is one last one, and it's kind of an interesting point to make off of what you just said, that you may not know if your parents had any type of mental health issues because, like you said, they weren't diagnosed in the same way, 30, 40 years ago, perhaps. And it can be hard to know if you're experiencing something genetic or not. So the question is, if you recognize some of the behaviors in your parents as you grew, maybe it's depression or anxiety, um, is that something that you could talk with your provider about as well if you have concerns about a genetic carryover?
Yeah, I definitely think that is something that you should mention to your physician. because that is an important factor. We know now that, you know, parents who have or have had anxiety or are or increased anxiousness, you know, that can manifest in the children as well, and it may show differently, but it's important to mention to your physician that. And you know, maybe providing some examples of things that you observed, which can be helpful. Um, so you know, getting that kind of maybe list together of these are the things that I saw in my parents, um, does help with some of that diagnosis piece. But um, again, environment influences how you react to different things, but also the types of experiences that you had as a child will also influence your mental health too. And so we call those adverse childhood experiences, but we do know that someone who, as a child, has experienced either trauma or stressful environment, they're at increased risk for different things. One of them is anxiety and depression.
Okay, and I think the answer to this is probably yes, but if you have a patient who is having trouble sleeping, and you suspect that it could be like a sleep apnea issue, then you would order separate testing for something along those lines as well, correct?
Yes, that is absolutely correct. Sleep apnea can cause poor sleep or poor quality of sleep. And like we had discussed before, if you're not getting good sleep, that can have significant impact on your mood. So we do screen for sleep apnea as well in our clinic. And there are certain risk factors for sleep apnea that we're always on a lookout for. And if we do notice that, we always try to refer patients to for a sleep study to our sleep medicine office.